This is all about ACLS. Remember, when we're doing ACLS, it's always important to do BLS, then ACLS. We're going to check for responsiveness, shout for help, activate the emergency response system, push the code button. We're going to yell for someone to obtain the AED or defibrillator. We're going to check the breathing and check for a pulse. We're not going to spend more than 10 seconds doing this. We're going to begin CPR if no pulse is detected. And if the pulse is present, we'll start rescue breathing. Our compressions are 100 to 120 per minute. We're going to sing Staying Alive by the Bee Gees or Baby Shark. And respirations are 1 breath every 5 to 6 seconds. Airway, we're going to maintain a patent airway in unconscious patients. We might use an oral airway. This just helps keep the tongue in its place, and it leaves enough area for air to go in. The patient may get an ET tube, and there may be nasal pharyngeal airways placed as well. We're going to be confirming CPR and ventilation with continuous quantitative waveform capnography. So waveform capnography attaches to the ET tube or the ambu bag. It can show adequacy of CPR. Less than 10 is a high mortality rate, so that means our CPR is of poor quality. It can also show ROSC, which is return of spontaneous circulation, and we will have sharp increase in waveform as seen in the bottom picture on the right. The image below on the left is a normal waveform, and the end tidal CO2 is 35 to 45. We need to supply oxygen as needed, and if it's an arrest patient, we are going to supply 100% oxygen. You can actually hook oxygen tubing up to your ambu bag. For stable patients, we're going to titrate that for whatever they need. We want to make sure we don't excessively ventilate our patients. It's 1 breath every 5 to 6 seconds. And remember, agonal breaths are not normal. This is the first sign of a cardiac arrest, and we're going to start CPR immediately. We're also going to have, we're going to monitor CPR quality with that waveform capnography, and we're also going to watch technique. We're going to be attaching the monitor or defibrillator during compressions. We're going to minimize interruptions. Our pulse check should be only 10 seconds or less, and we're going to do that only every 2 minutes. When the person is performing CPR and they start to provide ineffective chest compressions or they're getting tired, we need to give constructive feedback. We always should turn the AED on first and then follow the prompts if some people forget to turn it on. So notice the posture of the gentleman who's giving CPR. It's a bending at the waist and using the upper body's weight to press down on the patient that produces the best body mechanics during CPR. It is not bending the elbows and using the shoulders. So this is all in the waist. Circulation is maintained by obtaining IV or IO access. We're going to give appropriate medications. We're going to give IV fluids. We might be checking glucose, temperature, and cap refill. And we always want to keep the blood pressure at the minimum of 90 systolic. That is the lowest it should go. We're going to perform a neurocheck, Glasgow-Coma scale. We're going to check for trauma, bleeding, burns, marks, medical alert bracelets, and signs of IV drug use, and this is a disability screen. When we're doing the secondary survey, we want to remember the word sample. So we're looking for signs and symptoms, allergies, medications, past medical history, last meal or last liquids consumed, and events that led up to the patient's state. When we're going through the code, we're also reviewing the H's and T's. So hypovolemia is the patient having excessive loss of fluid. Are they dehydrated, malnourished? Are they bleeding? Hypoxia, this is obviously that they have not enough oxygen. Hydrogen ion, this would be acidosis or alkalosis. So this hydrogen ion is our pH scale. So this would be anything that would cause any of those. And then hypo and hyperkalemia, hypothermia, tension pneumothorax, tamponade, toxins. This could be drugs. This could be exposure to outside things like chlorine, like we learned about. Thrombosis, this is pulmonary, so this is a PE. And thrombus coronary, this is actually a thrombus inside the heart. And then ventricular fibrillation and pulseless, this is the key word here, ventricular tachycardia. This is part of our ACLS algorithm for cardiac arrest. So follow through that. It's an unstable situation. We need to act fast. It is definitely shockable. We want to defib the VFib. Okay, I don't have a fun rhyme for pulseless VTech, but that's the other one we have to remember. The first line medication is epinephrine, 1 milligram, and we're going to give it every 3 to 5 minutes IV. Second line medication is amiodarone IV, and this is the bottom right is VFib, and the bottom left is pulseless ventricular tachycardia. How do we know it's pulseless? Well, we take their pulse. You cannot tell someone's pulse by a monitor. You might get a rate, but it's actually just counting waveforms of the heart. That doesn't mean the patient has a pulse. So for these two, we're going to do CPR, which is compressions, breaths. We're also going to do epinephrine, and we're going to shock. Okay. And asystole and pulseless electrical activity, this is the other side of the cardiac arrest algorithm. This is also unstable, and we have to act fast, but it is not shockable. So you can't shock a rock. And so you're going to do CPR, which is compressions and breaths, and you're going to give epinephrine every 3 to 5 minutes. So asystole, of course, is like the flat line, the typical thing you always see on TV. Pulseless electrical activity is any rhythm. It could be regular or irregular, any rate, fast or slow, and it may or may not have P waves, but it is basically the heart's still sending out the electrical signal to pump, but the heart has complete failure because there is no pulse. So you can have an organized rhythm and no pulse. So post-cardiac arrest and return of ROSC, which is return of spontaneous circulation. You have pulse and blood pressure, and we're going to be maintaining their oxygen sats greater than 94%. We're going to treat their hypotension, and we'll do a 12-lead EKG. Remember, this is a picture in time, and it's more sensitive. This patient will be normally on cardiac monitoring, but this 12-lead EKG might just give us an extra peek into the picture of what's happening. We're also going to start temperature therapy. So basically, we're going to cool the body down to help prevent and reduce brain inflammation that occurs after cardiac arrest. Stable patient with an arrhythmia. They're going to have normal blood pressure, no chest pain, normal mental status, oxygen is adequate, and respirations are normal, and they're conscious. I paint this picture because we need to know the difference between a stable patient and an unstable patient when we're dealing with the two algorithms, bradycardia and tachycardia. So an unstable patient with an arrhythmia is hypotension, poor oxygenation, bradypnea or gasping breaths, pulseless, unconscious, chest pain, or altered mental status. So tachycardia with a pulse is a heart rate greater than 150. It's also called SVT. So stable patients, we're going to find and treat the cause. So this is stable as defined 2 slides ago. We're going to get a 12-lead EKG. We're going to take their vital signs. We're going to maintain their airway. So we're going to make sure they're not going to have any condition like fast respirations or anything that they could aspirate. We're going to ask them to do the Valsalva maneuver, and it is like bearing down, like having a BM. Basically, this restarts the heart's electrical current, and hopefully they will return to a normal sinus rhythm. But if this doesn't work, we can give a medication called adenosine, and we will give 6 milligrams. It is a rapid IV push followed by 20 mL of normal saline, and we usually use a 2-way stopcock. This allows us to not delay in pushing the adenosine followed by the normal saline. It's much faster. We just have to flip a little switch with our thumb, and we don't have to change syringes on the IV. For unstable patients, we will use synchronized cardioversion, and if they have a wide QRS, we might consider an antiarrhythmic or adenosine. So what is synchronized cardioversion? So it basically delivers a smaller electrical shock to the R wave. Remember, it's the R wave, and the cardiac cycle in the monitor. The monitor must be set to sync, and it will sync to the patient's cycle first. The cardiac cycle is regular, and the monitor can detect that R wave. That is when we can use synchronized cardioversion. And defibrillation, this is what we use for the pulseless VTach and the VFib. It'll deliver a higher dose of electrical shock to any point in that patient's cycle because it's not producing an R wave or a recognizable pattern. So it's used when the heart's only quivering. So basically what happens in the shock is it depolarizes all the cells, and it allows the cells to repolarize, and it resets the pacers to allow them to dominate their original pacing role. So bradycardia with a pulse, heart rate is less than 50. If they're stable, we'll continue to monitor. We'll let the doctors know, of course. If they're unstable, we'll treat immediately. So the first line medication is atropine. It's 0.5 milligrams every 3 to 5 minutes with a maximum of 3. So a good way to remember atropine is it rhymes with trampoline, and it makes your heart bounce faster. So you can also use dopamine drips or epinephrine drips. They might have transvenous pacing and cardiology consult. So they can have pacing with our defibrillators. There is a pacing mode, and basically it syncs that heart rate again, and then it can actually maintain a heart rate. We usually set it between 60 and 70 for them to have pacing when the heart needs it. And this is temporary until they can get a pacemaker. Here are the drugs that you need to memorize. There's not too many, but here they are and what they do.